One. Good evening, our dear friends and viewers from CEC all over the world. Upon your requests, this is the third wave of the Best of ESC Guidelines 2021 meeting that was for the Principality of Cardiology update. Tonight, we have a very interesting part of this updated guidelines, the part related to the preventive cardiology. And this will be presented by our dear friend and co-founder of CEC, Professor Haitham Suleiman Gharib, Lecturer of Cardiology at Al Fayoum University. So, Professor Haitham, you can start.
Thank you, dear Zohran. It's always a pleasure and an honor. There is many important topics and new recommendations in the 2021 prevention guidelines. The first one is the stepwise approach to individualize the cardiovascular prevention. They introduced two scores, or it's a one score with two modifications, the score 2 and the score 2 older people for 4 geographic regions. They were more specific about the risk of every geographic region. They had an age-specific risk threshold, even in apparently healthy people, which is very important. They have an estimated of lifetime cardiovascular risk and treatment benefit as an option. One of the most important concepts is the shared decision, because they involved the specific condition, preference, lifetime risk, and treatment benefits into account, and the patient preference, of course, of choosing his tailored management according to his risk. They emphasize the role of the environment and the recommendation for the environment and signaling potential cost issues. So in every category, we will observe that they have the risk, the initial risk category, which is even the apparently healthy people, the patient with established cardiovascular disease, specific risk conditions like diabetes, CKD, familial hypercholesterolemia, and they calculate the risk as the first step. And they look for the risk modifier, like the psychological stress, which is a new risk modifier, the ethnicity, the imaging, the comorbidities, and they inform a discussion whether these risk factors do have an effect on the risk or the global risk of the patient or not. Then they personalize the treatment decisions, looking for the individual level of intervention and treatment goals, like the lifestyle modification, psychological factors, risk factor treatment, antithrombotic therapy, and disease-specific, along with the population level of intervention. So here, the intervention is tailored to the individual level and is shared with the population level to tailor the most effective risk prevention strategy for every patient. And they included the apparently healthy patient who established coronary artery disease, diabetes, and CKD with 2 steps. The first step is to identify the prevention goals and the estimated 10-year cardiovascular risk using the score 2 and the score 2 older people, consider the risk modifier, and emphasize the prevention goal. Then they do an ultimate risk control based on the lifetime cardiovascular risk, the comorbidities, and the patient preference to reach the ultimate prevention goals. So here we have 2 levels of prevention, the initial prevention goal and the ultimate prevention goal. Of course, in the established vascular disease, cardiovascular or cerebrovascular, there is no initial goal. It's always the ultimate goal. And for CKD and familial hypercholesterolemia, there is a direct goal to reach and not a prevention goal and the ultimate goal. And this is the new category of the risk, which is very specific, and it has a tendency to increase from west to east. West is the less risk, and east is the more risk or the highest risk, and from north to south. And we, as expected, are tagged as a very high risk population from the start. So any score will to be applied in Egypt will be the very high risk score and nothing else. And this is the difference between the risk scores. And here there is also a new risk item replacing the cholesterol or total cholesterol with the non-HDL cholesterol, which is more specific and more risk-oriented than taking into consideration the total cholesterol level. The other risk factors did not change a bit, like the hypertension, systolic blood pressure, the smoking, the gender, men or women, and the age. And as we see, this is the low-risk patients. We have a lot of greens and yellows in young population, except for patients with very high non-HDL cholesterol and smoker men. As we go to the moderate risk, the reds are more prevalent, and in high risk, the reds are more prevalent, and in our own scores, the reds almost occupy all the chart. So we have a heavy risk burden in our patients that needs to go to the ultimate risk prevention and not to the initial risk prevention. In the apparently healthy people, stop smoking and lifestyle recommendation with a systolic blood pressure less than 160 millimeter of mercury in any age and in any risk category, even if there is no risk at all, is mandatory. It's class 1 before even begin to calculate the risk of this individual. Then age come less than 50, from 50 to 69 and above 70 years. Then the score, which is the score 2, is applied to each risk category with each age to see whether it's low, moderate, or high risk. Gathering this information with the risk modifiers will tell us whether to do no additional prevention goals or to go to the primary prevention goal, which is the systolic blood pressure less than 140 and an LDL cholesterol less than 100 milligram per deciliter. Even in the elderly people, which tends to have a systolic blood pressure, if tolerated, 130 millimeter mercury. And then try to intensify these prevention goals by taking into consideration not only the estimated 10 years cardiovascular risk, but the lifetime cardiovascular risk, the comorbidities and frailty, and patient preference to reach a goal of systolic blood pressure less than 130 if tolerated, and an LDL cholesterol of less than 70 milligram per deciliter, and in our case, less than 55 milligram per deciliter. We are talking now about the apparently healthy person without any established cardiovascular disease. So it's begin to be tighter and harder that any patient with multiple comorbidities, with high risk scores, with lifetime cardiovascular risk that is elevated, we should decrease the systolic blood pressure into less than 130 millimeter mercury, and it's class 2A to decrease the LDL cholesterol to less than 55 millimeter mercury. The elderly people are friable people, and if they are at high risk, meaning that the risk score is more than 15%, we should opt for the primary goals and then individualize the ultimate risk decrease, because they are sensitive for decrease in the systolic blood pressure and decrease in the LDL cholesterol. So if the patient is young, he will be considered a very high risk if he has a score more than 7.5%. If the patient is old, above 70, he's considered as high risk if the score is above 15%. So as we go older, the risk score is going older with us or increase with us. And this reflects the prevention goals in the apparently healthy individuals. Again, we opt for an ultimate decrease in systolic blood pressure and in LDL cholesterol in our patients because we are a very high risk category. So below 50, if there is multiple comorbidities, we must have an LDL less than, or we should have an LDL less than 55 milligram. And this goes from 50 to 69. But if this is an older patient with a score older people more than 15%, we should individualize the ultimate risk, either to stop at the prevention goal first step, which is systolic blood pressure less than 140 millimeter mercury if tolerated, and LDL cholesterol less than 100 milligram. And other than the LDL cholesterol levels that we all know, and we all know how to deal with, either to reach the goal or at least reach more than 50% reduction of the baseline, there is a direct recommendation now of involvement in a weight loss program using a low-calorie diet, then reintroduction of normal food or the usual food of the patient with a weight maintenance early after diagnosis, which can lead to diabetes mellitus remission, and this should be considered. So it's not only about decreasing the cholesterol of the patient, it's also about engaging this patient in a weight loss program that is low in calories with a phases of reintroduction of food to decrease his diabetes mellitus and his liability to be a diabetic patient. In patient with established coronary artery disease, the steps are more modified and more intense. The first step is stop smoking and lifestyle recommendation, and LDL cholesterol less than 70 milligram per deciliter, a systolic blood pressure less than 140 to 130 if tolerated, and an antithrombotic therapy. These are all initial treatment. And then comes the intensification of the treatments with the calculation of residual 10-year risk, lifetime risk, comorbidities, patient preference, to reach an ultimate goal of systolic blood pressure less than 130, and LDL cholesterol less than 55, and the use of dual antiplatelet therapy, icosapent-ethyl, and novel interventions like colchicine. Patient with diabetes have an initial step that is stop smoking and lifetime lifestyle recommendation, and adoption of a tight glucose level with an HbA1c of less than 7%. Then we look for the established cardiovascular disease or severe target organ damage. If there is The management is also intense with a tight control of systolic blood pressure, a tight control of LDL cholesterol, the use of antithrombotic therapy, and the use of novel anti-diabetic treatment like SGLT2 inhibitors and GLP-1 receptor agonists, which showed a benefit in cardiovascular morbidity and mortality and decrease in cardiovascular hospitalization. But if this patient is without target organ damage, without an established acute cardiovascular disease, and with a moderate risk, there is no additional prevention goals to be reached. But if he's a high risk, even without established cardiovascular disease target organ damage, there is an intense or moderate intense goals with a systolic blood pressure less than 140 and LDL cholesterol less than 100 milligram per deciliter. Then we also calculate the risk again to try to intensify the management of our patient with a tighter control of blood pressure, of LDL cholesterol, and the use of GLT2 inhibitor and GLP-1 receptor agonists. And if the patient with established target organ damage or SVD, we should decrease the levels of LDL cholesterol to less than 55. The use of SGLT2 inhibitors and GLP-1 receptor agonist is class 1. It's mandatory now. And we consider the use of DAPT, the icosapent-ethyl, the colchicine as class 2B according to every individual risk. And this reflects the goals either with or without established cardiovascular risk or target organ damage. For patients with CKD, the initial management is the same, which is stop smoking and lifestyle optimization, seeking a systolic blood pressure less than 140 and an LDL cholesterol less than 100 milligram per deciliter. If there is an established diabetes or ASCVD, we go to the table of the ASCVD or the diabetes. The CKD will be now a risk modifier and not the initial risk of the patient. And if this patient has no established cardiovascular disease or diabetes, but yet has a high scores either in the 10-year cardiovascular risk score, the life risk score, or life risk modifiers, we tend to go to less LDL cholesterol of 70 milligram per deciliter or even lower in very high risk categories, which is again our situation. In familial hypercholesterolemia, the initial risk is the same, and the management is the same that of CKD. It's very important now to share with our patient his risk and the benefits that he will get from the treatment and what is the economic burden that he will get. It's now class 1 indication. It's very important to discuss with the patient what's gonna be and what he can do. Stress is now an established cardiovascular risk. So anyone with stress or psychological stressors, this will modify the cardiovascular risk of the patient and make him more liable for cardiovascular complication. Using of coronary calcium score is now class 2B, and the ethnic group is taken into consideration to multiply the risk of the patient. And again, like the last guidelines, it's not recommended to do urinary biomarkers, genetic risk scores, circulating biomarkers, and other imaging rather than the coronary calcium scoring to enhance the risk of the patient. Completing the cardiovascular risk is the risk of AF. And like hypertension, like dyslipidemia, like heart failure, and like ischemic heart disease, AF is more or less a modifiable disease in much of its risk factors. So the tendency is to detect the patients at risk of developing AF and try to modify this risk as much as we can. Try to detect the left atrial remodeling. If it's fibrosed, there is no reverse. Try to decrease or prevent the risk of stroke in patients with established AF, doing a rate control, doing cardioversion, catheter ablation, even surgery, and decrease the AF outcome, mortality, strokes, heart failure, dementia, myocardial infarction, and hospitalization. So they are now dealing with AF as a more modifiable disease that should be prevented from the start. And if it happens, we should prevent the drawbacks of the AF. Of course, patients at very high risk of cardiovascular disease may be encouraged to try to avoid long-term exposure to regions with high air pollution. This is extremely important now, and all the trials indicates that high air pollution increase the risk of cardiovascular disease of these patients and increase the events, cardiovascular events of this patient. And if there is no hope to decrease or change the life environment, opportunistic cardiovascular risk screening programs may be considered. That is to say that apparently healthy individual with high risk profile can be screening from time to time to see if there is an established cardiovascular disease or not. For the CKD and cancer, all CKD patients with or without diabetes, appropriate screening for cardiovascular disease and kidney disease progression, including monitoring changes, is recommended. This is class 1. For cancer patient, it's recommended to monitor and to evaluate the cardiac condition before, during, and after the cancer treatment. It's now class 2B to give cardioprotection in high-risk patients, whether there is a decrease in myocardial function or not, especially if these patients are liable for cardiotoxic anti-cancer treatment, and screening for ASCVD risk factors and optimization of cardiovascular risk profile is recommended in patients on treatment for cancer. For COPD patient, it is recommended to investigate all the COPD patient for the presence of cardiovascular disease and cardiovascular risk factors. Inflammatory conditions are now considered as a multiplier factor for risk, for cardiovascular risk, with as high as 1.5 increase in risk in the presence of inflammatory condition. And migraine is now considered as a risk factor for cardiovascular disease, as it's combined with higher risk of cardiovascular disease and higher incidence of cardiovascular morbidity and mortality. Sleep breathing disorders are very, very important, and it's occasionally skipped in our clinical evaluation. So patient with established cardiovascular disease, obese, and hypertensive, you should look for sleep breathing disorders. And if the management failed, which is the spending more than 4 weeks to sleep hygiene, to sleep better, to change the position, to try to decrease weight, please refer the patient to a specific clinic to solve the problem of sleep breathing disorders and obstructive sleep apnea. Mental disorders are extremely important. They are considered as a cardiovascular risk, and they influence both the prevention and the management of cardiovascular disease. So mental disorders are now taken serious with the class 1 recommendation to look for cardiovascular risk factors in this category of patients and to deal with them as high-risk patients. Sex-specific conditions, women with a history of preeclampsia and pregnancy-induced hypertension should have a periodic screening for hypertension and diabetes. Women with a history of polycystic ovary syndrome and gestational diabetes should have a periodic screening for diabetes. Women with a history of premature stillbirth, periodic screening for hypertension and diabetes is wise. It may be considered, and the assessment of cardiovascular risk should be considered in men with erectile dysfunction. As for physical activity, the optimum is to have from 75 to 150 minutes of moderate intensity exercise and physical activity per week. If you cannot, you are asked either to engage in a lifestyle intervention group or in an assisted physical activity group, or try to reduce your sedentary lifestyle as much as you can to engage any physical activity during the day. If you cannot achieve the threshold of 75 to 150 minutes of walking or moderate intensity exercise per week. So any change in the sedentary time is recommended. It's class 1, and the more you engage in a physical activity exercise, the more you will get the benefit. What about nutrition and alcohol? It's recommended to have a healthy diet, to adopt a Mediterranean diet, to replace saturated fat with unsaturated fat, to decrease the salt, to choose more plant-based food pattern than the red meat or the protein-based diet, to restrict alcohol consumption. It's recommended to eat fish preferably, and to restrict free sugar as much as you can to less than 10% of your energy intake per day. And this is the known healthy diet characteristics. It did not change a lot. And regarding the body weight, any overweight and obese people will aim to reduction of the weight to reduce blood pressure, dyslipidemia, and risk of type 2 diabetes, and thus improve the cardiovascular risk profile. The ranges of diet are various, but we recommend a healthy diet regarding the cardiovascular risk. So you must tailor the diet of your patient aiming to or looking to the cardiovascular risks and not only the decrease in body weight. And if this measurements fails and this intervention fail, bariatric surgery could be a solution for these patients. And for recommendation of mental health and psychological, again, the high-risk patient should be considered as very high-risk patient if they have a continuous mental stress. The use of antidepressant and SSRIs are encouraged in patients with coronary artery disease and moderate to severe major depression. And patients with heart failure are discouraged to use SSRIs as SNRIs and tricyclic antidepressant. They are not recommended for heart failure patients. So mental health is extremely important. Smoking intervention, all tobacco should be stopped. And this is very important because now we have every now and then a novel type of smoking claiming that this is a safer type and a safer form of smoking, whether it's electronic smoking, whether it's non-combustible smoking. All these types are considered smoking and should be prohibited and stopped immediately. in smoking, offering follow-up, nicotine replacement therapy, vernicline, and bupropion is considered and should be done, and smoking cessation is recommended regardless of weight gain, which is a very important part and an arguing part between the physician and the smoker, that if I stop smoking, I will have a weight gain, and this will increase my risk. So what did I benefit? The risk of weight gain is less than the risk of smoking. So even if the patient gains some weight, this can be modified, but it's very important to smoking cessation at once. And this is how we convince our patient. This is the live cardiovascular disease risk model. And if we see here, this is the benefit and percentage benefit that you will get if you decrease smoking. And the younger you are, the more benefit you will get. So this chart should be shown to the patient to convince him that his risk will considerably decrease after 1 year, and it will continue to decrease. And there is a very brief advice of smoking cessation, which is ask, advise, and act. Ask about the establishing and recording of smoker status of the patient. We must record the smoking status of all our patients. We should advise the patient to stop smoking, and we should offer help engaging the patient into a program or giving a treatment to the patient to help him stop smoking. Of course, the continuous screening of hypertension is very important. If the patient has, or the individual has, an optimal blood pressure less than 120/80, he should repeat his blood pressure management at least every 5 years. If he has a normal blood pressure, repeat it at least every 3 years. If he has a high normal blood pressure with no muscular hypertension, repeated annually. If there is muscular hypertension, do an out-of-office blood pressure to detect the muscular hypertension. And in hypertensive patients, you should have a strict program to repeat visits for office blood pressure or out-of-office blood pressure measurement. For diabetes, screening for diabetes is class 2A, even in patients without any cardiovascular apparent risks, using an hemoglobin A1C. Lifestyle modification, smoking cessation, engaging in an aerobic physical activity is class 1. Reduction in energy intake is class 1. For those motivated to try, consider weight loss, which is class 2A, to decrease the diabetes, again, with a low-calorie diet, intermittent with reintroduction of the normal diet of the patient, taking into consideration that this normal diet of the patient do not contain any processed meat and any high caloric diet, the regular and reasonable diet. Glycemic targets, the optimum target is less than 7% hemoglobin A1C. You can consider in older and frail adult a less strident hemoglobin A1C targets, and target of hemoglobin A1C of 6.5 should be considered at diagnosis or early in the course of type 2 diabetes in persons who are not frail and do not have cardiovascular disease. So in patients with cardiovascular disease, it's 7%. Without cardiovascular disease and not frail, it's 6.5%. In older patient and frail patient, we can allow for a more increase in hemoglobin A1C than 7%. Metformin. Metformin is a class 1 lifetime therapy in the majority of patients without previous ASCVD, CKD, or heart failure. Type 2 diabetes and cardiovascular disease, metformin should be considered. and avoidance of hypoglycemia and excessive weight gain should be considered and should be looked in these patients. The GLP-1 receptor agonist and the SGLT2 inhibitors are strongly represented in these guidelines in patients with type 2 diabetes and established cardiovascular disease. It's class 1. In patient with target organ damage of diabetes without cardiovascular disease, SGLT2 inhibitor is preferred. It's class 2B. SGLT2 inhibitor is preferred in CKD patient, whether there is established cardiovascular disease or not. SGLT2 inhibitor is again class 1 indication in patient with type 2 diabetes and heart failure with reduced ejection fraction. And in patient without all these risks, only type 2 diabetes, it's preferred to shift to SGLT2 inhibitor or SGLP1 receptor agonist to reduce the risk of having a cardiovascular disease and decrease the adverse events of cardiovascular disease and renal outcomes. So even the patient is not an established cardiovascular disease patient, do not have hypertension, heart failure, CKD, it's preferable now to use the SGLT2 inhibitors and SGLP1 receptor agonist, looking to the benefit they do of decreasing cardiovascular risk and hospitalization. Antithrombotic therapy. Aspirin is recommended as a secondary prevention of cardiovascular disease. Clopidogrel can be an alternative to aspirin if aspirin is not tolerated, and it's class 2B to replace the aspirin with clopidogrel in tolerated patients who can tolerate aspirin. It's class 2B. Proton pump inhibitor is a must when you use antithrombotic therapy. Patient with diabetes and with high or very high cardiovascular risk, a low dose aspirin may be considered as a primary prevention. It's now class 2B, and it's prohibited to use antiplatelet therapy in individuals with low and moderate cardiovascular risk due to the increased risk of major bleeding without high or very high risk. Colchicine is now, a low dose colchicine is now considered a class 2B in prevention of cardiovascular disease, particularly if other risk factors are present. So colchicine now, a low dose colchicine is considered for secondary prevention of cardiovascular disease, along with aspirin, of course. Cardiac rehabilitation is a must for every patient with ACVD, mainly heart failure, and you can tailor the cardiac rehabilitation whether by engaging the patient into a remote cardiac rehabilitation program using electronic facilities, automated referrals, and or home-based cardiac rehabilitation therapy, but do as much as you can to engage these patients in a cardiac rehabilitation program. And this is one of the examples of engaging the society into the cardio risk prevention of patient, which is the smoking cessation. Other governmental restriction of smoking to prevent smoking in public areas, in closed area, to ban tobacco vending machine, to restrict the use of tobacco for young patients, and to increase the taxes on tobacco. And in media education, they are requested to decrease or to prohibit any publicity of smoking and to increase the public awareness program to emphasize the risk of smoking and the benefit of quit smoking. And thank you so much.
Thanks a lot, Dr. Haytham, for this excellent overview. And actually what I loved about it is that it focused on the points that have been changed or updated in this field. Let me highlight some points. Actually, it's very important now to understand that the lifestyle measures have been expanded and its role has increased, starting from the smoking cessation, starting from the healthy diet, starting from the weight control. And with the spread of e-cigarettes, it's also mentioned now that e-cigarettes has risk also similar to that of the regular cigarettes, and it should not be used as a step like we are reducing the risk by using these e-cigarettes. What I also want to highlight is that the hypertriglyceridemia has been recognized now as a cardiovascular risk factor, and the new icosapent ethyl has been now mentioned by name and by the dose in the cardiovascular disease risk prevention. Let's also highlight upon the cardiac rehabilitation programs, which now have been also mentioned by name and taking a class 1 recommendation, where previously in the past era of the guidelines, they have been said that they probably reduce, probably improve, but now it's a class 1 level of evidence A. And let's also highlight the introduction of the new medications, which are the SGLT2 in the diabetes and the HFpEF and the HFrEF. And apparently those drugs are a game changer in the cardiovascular prevention for the treatment of diabetic patients and the treatment of patients with normal ejection fraction who are still at the risk of cardiovascular disease. Thank you so much, Dr. Haytham, for highlighting this very important section of the guidelines, the cardiovascular prevention. We have Dr. Mohammed Abshafi, also lecturer of cardiology from Suez Canal University. Dr. Mohammed, would you like to highlight something from Dr. Haytham's lecture?
Yes, thank you very much, Dr. Mohammed. Dr. Haytham, elegant presentation as expected, a very nice highlight, addressing the critical issue of cardiovascular medicine, which is prevention. The most cost-effective guidelines should be it, although maybe the least adopted and the least focused upon. I have a few remarks and one question. The first one is that I agree and I applaud actually the European Society of Cardiology for making the last of the scores that you have mentioned, the overtime reduction in risk when cessation of smoking is adopted. Because I actually do this in my clinic. I calculate for my patient their overall risk while ticking that they are smokers, and I repeat risk calculation, removing smoking from the risk category, and it counts a lot, specifically as have mentioned in the younger age groups, because the age has a very great weight in older age groups in the risk that actually dilutes the effect of smoking a little bit, but in younger age group that counts a lot, and that is very encouraging and motivating for a lot of patients. The second thing is, of course, the highlighting of using the SGLT2 inhibitor in prevention of cardiovascular disease in high-risk patients with diabetes. And actually, I think as cardiologists, we are adopting this pathway much ahead of endocrinologists and even much ahead of nephrologists. It's almost the other way around, at least in my practice, that a lot of these patients I prescribe such a group. And unfortunately, if the patient has some sort of issues of controlling their diabetes and they are rather needing complex treatment regimens as insulin basal bolus and uncontrolled diabetes, and it happens that they are sent to the diabetologist, a lot of them return back with the SGLT2 inhibitor taken off with no proper justification for me. Also in CKD, patients with mild to moderate CKD who are going to benefit a lot of them, because of the creatinine sensitivity or creatinine central approach of a lot of nephrologists, come back without the SGLT2 inhibitors that I have prescribed. And I think this should be focused upon more in the future. And lastly, a question. My question is that maybe I'm mistaken or confused, but I saw the level of recommendation of icosapent ethyl for secondary prevention in cardiovascular disease, whether diabetic or not, as class 2B indication. But I remember in dyslipidemia and hypertriglyceridemia, or even triglyceride above 150 after treatment of statin, that it was class 2A. I don't know if this is some sort of conflict, or maybe I misunderstood or got a little bit confused. And again, thank you very much, Dr. Haytham, for such a great presentation.
Thanks a
You're
lot,
welcome, dear.
Dr. Mohammed.
Thank you, Dr. Mohammed. No, there is no conflict, because here, and let me show you in the established cardiovascular disease, this is the optimum dose of prevention. So the prevention guidelines consider hypertriglyceridemia as a separate, or not a separate, but it's a unique entity of disease. We are trying to treat this disease. But the class 2B recommendation for the icosapent ethyl is for prevention, not for treatment. So this is the optimum or the ultimate level of prevention, even if the triglycerides level are not that high to mandate treatment. And the class 2B recommendation is for the whole package, the dual antiplatelet therapy, the icosapent ethyl, and the colchicine. This is for secondary prevention and not for treatment. But for treating dyslipidemia or treating hypertriglyceridemia, it's class 1 indication to use the icosapent ethyl if the triglyceride level is increased up to 135 milligram per deciliter in very high risk patients. It's class 1, and this is for treatment. But the class 2B is for the prevention and not for the treatment.
So again, does the same problem face you with when prescribing SGLT2 inhibitor if your patient happened to go to an endocrinologist or a nephrologist?
Of course, this is a constant, very well-known problem. And this is a double-bladed sword problem for us cardiologists, is to convince the endocrinologist that these drugs are more preferred and will be more beneficial to the cardiovascular patient or the cardiac patient, and to convince the patient, the non-diabetic patient, that SGLT2 inhibitors is not meant to be taken for diabetes, it's for the cardiovascular benefits. This group of drugs must have a more spread of knowledge between the general medicine, the nephrologist, the diabetologist, and endocrinologist, and even the pharmacist, in order not to face these problems. Either to tell the patient you don't have diabetes, so why you are prescribing an anti-diabetic treatment, or to be turned back from the nephrologist and endocrinologist for refusal of this group of medicine, of drugs.
Yes, I think part of this problem, and we have additional flags for it, is still a lot of internists and some endocrinologists, although despite the advances, are still glucocentric in their approach to their patients.
Yes.
And the other earlier flag is that a lot of patients coming from them, type 2 diabetic patients, are not prescribed statin. So I think this is an extension of the same problem.
Yeah, yes, you're totally right. They have issues with cardiac prevention, and they have issues with risk estimation and risk factors identification and recognition. And these issues must be dealt with rapidly, because we're now in the same room, and the opinion of each other do count, and the patient will end up refusing the treatment of both of us if there is a major controversy. Yeah.
Yeah.
This is a problem that should be treated early.
Yes. Yes. Again, thank you, Dr. Haytham, and I'm
Welcome.
very delightful to be joining you tonight. Thank you
The
very
honor
much.
the honor is ours, dear.
Thank you, Dr. Haytham.
Thanks a lot, Dr. Haytham, and thanks a lot, Dr. Abshafi, for this wonderful discussion. And this part of the guidelines is always interesting, and the updates were highlighted in a very elegant way by Dr. Haytham. I enjoyed it so much. So the last wave will be next Thursday. It will be the cardiac pacing guidelines, which will be presented by Dr. Mohammed Abshafi, and an update of the remainder of the trials that were not discussed yet. Hopefully will be discussed also in the second half of next Thursday's webinar. We are glad that you all joined us tonight, and we hope this had been of use and help to all the cardiologist family joining us at CEC. Thanks a lot to all of you, and see you next week, inshallah.
Inshallah.
Stop recording.